going to introduce you to Desimone, our clinical wound nurse, and she can start the webinar. Thank you so much, guys.
Hi, everyone. If you're me or can't see things, feel free to write something on the side. We did go through everyone. It looks like everyone is able to see everything. I'm going to go through things, and if you have any questions, you can type your notes in, or I'll give at the end, I'll give my phone number and my email, and you can send them that way as well, so that I'll be able to answer questions. We mute everybody only so there's not interference and static, so that's why I can't answer them probably till like the end. Anyway, this is going to be on a bridging application. Okay, everything that I do on this one is pretty standardized. So let's get started. Okay, so I'm going to go through a few contraindications and warnings now. I think I have a few clinicians and a few representatives on here. I just want to be sure that all clinicians always really read all your contraindications, all your warnings. I do get a lot of calls on things like that. So I'll just briefly go over everything, but it's important that everybody really knows why negative pressure can and cannot be used. So it's important that if there's eschar present in a wound, you wouldn't want to put negative pressure on. What you would want to do is be able to get that taken care of first, whether it be sharp debridement by a physician or some type of a chemical debridement, something like that, so that you're starting with the cleanest wound you can. If there's a certain amount of slough in a wound, you may be able to initiate negative pressure, but that will be up to your physician. It will also be up to your assessment on if it's actually too much slough in the wound. Negative pressure actually sets up like an autolytic debridement. So there is a certain amount of debridement that will go on because everything's kept contained, nice and moist and warm. So there will be some autolytic debridement that will happen with negative pressure as well. You do not want to use it near or over a pacemaker. You do not want to use it in a wound where any malignancy has been present. So if a patient was to have cancer in another area of their body, then it may be appropriate at another site. Maybe they have a sacral wound or something like that from a pressure ulcer. That's okay, but if there's actually been a malignancy removed from that area, you would not want to start proliferating those cells again. You do not want to treat with any untreated osteomyelitis. You want to look at that and have that treated. You definitely do not want to use it on anything direct with blood vessels, any type of exposed nerves, organs, anastomotic sites, or anything like that is something that would be an absolute no. So if you have any questions or you know, clinical wise, have that checked out before you put something in. I always put down that you want to use high caution. Many patients are on anticoagulant therapy. So they could be on Coumadin, they could be on heparin. And it's not that you can't use it, it's you have to be very careful. A lot of different medications cause, they have like an anticoagulant property. So you want to make sure, because this will put your patient at a higher bleeding risk. So you want to take caution there. A lot of physicians put negative pressure in right after a debridement, but on that you just want to use a lot of caution. Again, you're always monitoring the patient more often in those situations. Unexplored fistulas, you always want to know where a fistula goes, and that's something, again, that it's through assessment and whether you determine, or a doctor determines if it's appropriate. So just read all your booklets, go through everything before you start. Wounds that are appropriate for negative pressure, you always need a physician order, so we'll talk a little bit about that. So you want your physician order in place, and then you want to do a very thorough assessment of the patient if they actually are able to use negative pressure. But these are typical wounds. You have your acute wounds, your surgical wounds. You might have a surgical wound that has dehisced, so that negative pressure is wonderful in those areas. Chronic wounds, a lot of times can be re-stimulated back. vascular and arterial wounds. Wound drainage management is a big situation that this is very helpful in. That's when you'll see some hospice patients utilizing it, and that would mostly be for comfort and dignity. Diabetic ulcers, pressure ulcers, we can treat from stage 2 through 4. Grafts, also a lot of physicians will start using negative pressure after a graft is placed. The only thing that you need to look at with that is what are the settings. A lot of times if the physician is using a graft, they'll actually decrease the settings from 125 to maybe around 80, somewhere around that, so there's not so much pressure to the graft site. And again, that would be up to the physician. Okay, so the only thing I want you to know as we go through this, the negative pressure presentation today, this is just a basic. I use a wound butt. So the area that I'm doing on, we're just sort of treating 2 wounds. It may not actually be to real life. And of course, every patient's circumstance is different, and there's so many complexities that nothing in my webinar can be exact to every patient, of course. But I do give my email at the end and my phone number. So if anybody did want to contact me. Okay, so my email is right here. So hollywcc@yahoo.com is a place that you can contact me to chat. Okay, so here's the kits. These are the Equinox kits, and they come sterile. And they have the black foam, the unidrape, the suction dome, and the adapter within. To make it simple, here they are right here. So we have a 1, 2, 3 drape, which is a great drape. The black foam, the dome, and here's the adapter. Okay, items that nurses should collect before going in, things like a good pair of scissors, exceptionally clean scissors, skin prep, saline solution, a wound measuring device. You might want to grab some 4x4s so that you can dry the peri wound so that you can actually get a good stick. And I always suggest strongly for everybody to bring in a good flashlight so that you can actually see inside that wound bed and know what's going on. Okay, the biggest thing that any nurse is going to do is to assess the wound, determine if it's appropriate for negative pressure, and of course you're going to make an assessment every dressing change. Measurements usually done weekly, and you're going to prepare the wound. So it's going to be per your facility protocol as far as how you prepare that wound. You're going to want to measure, and a lot of people use these simple paper measuring devices, but you're going to want to measure the wound. And then, of course, weekly is usually when wounds are measured and everything's documented. You're going to want to irrigate your wound bed. And I think this is one of the biggest things that nurses can do. Of course, you're going to follow your facility protocol. You're going to hear me say that an awful lot. But you want to irrigate. Now, we're going to bridge 2 wounds. So you want to irrigate both of the wounds as directed. But I think it's really important to know that you want to make sure you irrigate well enough that any fragments, anything at all that's left behind is going to wash out of that wound. What you irrigate with is, again, up to your protocol, but normally it's normal saline. Unless you're using something like a silver dressing, and particular silver dressings actually need sterile water to be able to irrigate with. So you want to take a look at that and make sure you're irrigating with something proper. But you want to get up in this area. If there's any fragments left behind at all, you want to make sure they're all cleansed away. Of course, we have a very small irrigator here, but I would bring in a bottle of saline, maybe a 5cc syringe, something like that, so that you can actually do a really thorough irrigation. You're going to do, after proper irrigation, of course, we're going to dry the wound area. We want to make sure, again, and you don't have to go in and dry the wound bed. Actually, the negative pressure is going to, but you want to get a little bit of everything out, so we make sure that this isn't getting wet and our transparent won't seal. So that's important. You want to apply a protective barrier to the wound. And here we use something like a skin prep. I like the non-alcohol based skin preps. They're a little gentler. But you want to go around the whole area. You might want to go take another one and go out a little further. So wherever you're putting transparent dressing, so in this case, we're going to be doing a bridge. So you're going to be making sure you skin prep the area that we're going to be doing the bridge at also. If you're using a non-sting skin prep, you want to make sure you give it time to dry. At this point, I'm a big person on window painting, sort of protecting the outer areas over here with a little bit of transparent drape or something that, again, your facility may use something to window pane. For the sake of just letting you know, again, this is a wound butt, so this is what we had to work with. But of course, we see here that bone is exposed, so we would be protecting that bone. We would be making sure that there is not osteomyelitis in the wound bed, and if there was, we would treat that. In this area, of course, would not be included. We would worry about that as having eschar. So, but we'll make believe that this isn't here for now. Okay, so we're treating these two wounds. So we have two wounds, and we're going to bridge an area so we can use one pump to treat two wounds. So here what we're doing is we're just basically laying a foundation and preparing the skin between the two wounds for the bridging. So the biggest thing is to make sure that we're protecting the integrity of the skin, especially the good skin. We don't want it bigger. So as you can tell, I've cut the transparent drape and I've sort of followed my wound bed so it's going right against it, because I want to make sure that nothing is going to get and penetrate onto my good skin. We want to keep that tissue healthy. So here, just laying it across between the two wounds. We don't want anything to macerate. Okay, so we've got it down. As you can see, I came very, very close to the edges because I want to be sure that that area is protected. Okay, the drape is fantastic that you'll be working with. I do really love the drape. If it's used correctly, you're gonna, remove number one, remove number two from underneath, and this is showing number three. If you can see, I'm holding the edge of the drape with one hand, and there's a little blue line right here. So you just hold that tab and then peel up right at this blue line. It comes right off. So when you look at the drape, you'll be able to see that area. And now you see we've got everything protected. We're just going to end up peeling off this blue tab and we're all set. And this is what it looks like after. Our two wounds have a nice, clear, transparent bridge between them. Okay, now you're going to get a great pair of scissors. And you need to cut the foam to be the correct size, of course, of the wound. Couple little points. You definitely want to make sure that you're filling your wound and you're not leaving any dead space. But if you do have any undermined areas, if you do have any tunneled areas, you wouldn't be using the black foam. You'd actually be using the white foam. The white foam has a greater tensile strength. It also does not fray at all. So that way it's very good to go in those areas. You don't want to overfill your wound with this, but the goal is to have the foam a little bit higher. And we'll go over a couple things because at times you're going to actually fillet this too, because this is a little thick. There'll be times you'll actually be doing a little off the sides that may come up later. So you're going to cut your uni foam, of course, to fit the wound bed properly. And as you can see, I'm not going to be over my wound bed. I'm going to be cut away from my wound bed so that no fragments are able to sort of drop into the wound as I cut. So I'm going to cut way over here. I'm going to dust it off way over here, and then I'm going to place my foam inside the wound bed. The area that you saw in the previous picture that was tunneled, I've already placed white foam in. And then I place my black foam over the white foam. Okay, so here we've got black foam in our first wound, black foam in our second wound, our bridge going across. You can see this up here. And you need to determine which wound at some point where your dome is going to be. And that will be an area that, to offload, the area that the patient is actually not going to be on. And as you can see, it's just coming out of the wound bed slightly because we want to be able to let this compress down. It is going to compress, so what we want is that once it's all compressed, it should be about, the height of the wound bed. And of course, we're always placing the foam very gently in the wound bed. We don't want to, we don't want the foam or for us to damage any of the tissue. Now what we're doing is we're creating the actual bridge. So we cut a piece of black foam right down. I filleted it down thinner. You don't have to do that, but I think the system works better that way. And I just made it a little bit thinner. It's very easy to do because I cut down the foam and then I just run right down the side. And as you can tell, I'm overlapping onto this wound. I'm overlapping onto this wound, so I make sure I have good contact. If there's a break in the contact, it's not going to work. And as you can see, I also have on both sides a protection layer. I'm not going right up to the side. So there's a nice protective barrier here. And as you can see again, here's again my overlapping to make sure that there's contact on both ends. Okay. And here, I'm sort of going to cut my transparent appropriately because what I'm going to do is I'm sort of just deciding now where my hole is going to go. Okay, the drape has to cover both wounds. So here we're going to just decide. I'm just sort of looking at it to decide where I'm going to cut my hole to put my dome. Okay, now what I've done is I've cut that down, the transparent down a little, because I don't want extra transparent on good skin. I want to sort of cut it down to the appropriate size. And as you can tell, these lines are where you would cut. That makes it easiest for you to still have all number 1, all number 2, and all number 3, so you're not going crazy with your transparent leader. I folded my drape in half, and I just cut a nice clear circle. Nickel size hole is what you're looking for. But by doing it this way, I get a nice hole. It's not going to tear. Now I'm just going to remove drape number 1. And then I'm going to turn it over onto the sticky side. As you can tell, here's my hole. My objective is to line it up over here. So I'm going to position it over the hole, right in the center of this foam, and that's where my dome's going to be placed. But I'm hoping, the hope is to get it all covered at once, this area. Okay, so I'm gently sealing down the edges. I'm not pushing, I'm not compressing anything down. I'm basically just following the curves of the body around so that everything is covered. I might make a little triangular cut here to make sure it's able to follow the curves of the body. Now, this is the drape number 2 part, okay? So you have to lift the sides of the drape and you go underneath, and there's a ridge, and it's a pretty big ridge, so it's just easy. You lift that up and you remove drape number 2 backing from underneath, and it just peels right off. And then you would again adhere it down to the skin. Okay, now this is number 3, and again, I put a lot of big arrows here just so everybody sees. There's a line right here. A couple people have had trouble with the drape, so I just thought that this is something to good. You're going to hold this side down while you lift this side up. So you're just going to hold this part of the blue tape and lift right here. It comes right up easy. I've never had it stick to my gloves. It's a really nice drape to work with. You take off number 3, and again, you'll be all set and it will go right here. Okay, so now everything's sealed down and you can tell everything's completely covered. And all I really do is, again, I follow my edges around. A lot of people, I've seen them stop pushing and compressing on this. That's what you don't want to do, especially on here. You don't want to stop putting pressure and pushing foam down in. It will, the negative pressure will do that for you. Okay, so now you're getting the dome and you're taking the backer off. There's a paper backing, and you just pull off the paper backing on the dome. This area right here, the top of your dome, the bubble top of your dome, is what's going to line up with your hole in your transparent drape. If they don't line up, then you may get blockages and things like that later. So that's an important step. Sometimes we do things so quick and we may be, half off and there's only half of it or even more than half. And I've seen where that can send things off saying there's a blockage. So you just want to be sure when you're placing your dome down that you're actually centering it over. Again, you're just going to place it here. And then again, all I'm doing is gently sealing the edges. Now there is a little swirly little swirly thing right here. I don't know if you can see it, but it basically goes like this and out. That's the top part of the backing on the transparent. And I do know that there's been a few times that it is thin, so the nurses don't really see it. It doesn't come off. And again, it will set alarms off because what you need is airflow to go through. It actually, even though these are, there's a certain amount of airflow that has to go through. And if this dome is all covered with that plastic, you may again get some blockage alarms. So they just want to make sure that they take this off. It should peel right around. And the idea is just to get in that little swirl, grab that with your finger and remove that backing. Okay, now I'm just going to remove the blue tabs. And then I just want to make sure that I secure right here all my double lumen tubing down. So you can do a chevron like you do with IVs. You can get some pink tape. If the patient has any skin integrity issues, you could always put maybe a small piece of black foam, a small piece of foam or something like that gauze under for it to rest on, because this is now the outer. We're not worried about anything. We could just put a little piece of gauze under here and then tape it down. But we just want to make sure that that doesn't pull up and stop pulling on our tubing here. I'm going to go back one and just show you. Another thing I've noticed in, the last few things that I've gotten in the last few months, very good, people want to keep their seal for 72 hours. So they get the idea, I'm going to take some more transparent and I'm going to recover this. It's not getting off, no way. And the problem again is that impedes airflow. So I just dealt with a couple things last week on that, that the airflow is getting impeded. The drainage was, and the alarms were going off. So I suggested to the nurses to do it over again and not put another layer of transparent down. What you can do is maybe if this is a loose area over here, then throw another piece down, or if you think there's a leak over here, throw a little piece down, but you don't want to go over the whole dome. Here we put a chevron down, so we've secured our dome. And this is what it looks like. It's all compressed. You're going to connect your tubing to your negative pressure device. You're going to go by whatever your physician orders are. Most of the time with the black foam, you see negative 125 continuous. There are times you'll see intermittent orders come, and the machines, of course, can do that as well. Every once in a while, you'll see the physician choose a lower setting, again, for certain situations. But now you're done. Now it's time to monitor the patient. It's definitely time to get in and tell your CNAs and explain to your CNAs that, it's a pretty important dressing. It's not done in a few minutes. So, protect that tubing and protect from pulling or from pulling along beds and things like that. And now it's time to monitor. I always say in the first 24 hours of initial, you definitely want to monitor quite often. And again, your physician usually gives you orders on that. The norm is they're changed like a Monday, Wednesday, Friday type of a situation, if that's the way your facility wants to set it up. And that is the end of the presentation. I do have some programs on strengthening some clinical confidence through, non-product based education things. So here's my email and here's my telephone number if you're interested in anything more staff development programs and things like that. And then I do know Joey and I have
June 16th.
June 16th, another webinar coming up that will be bridging to offload a wound. So instead of bridging two wounds together, it will be about offloading. Please write me, let me know what you think. And if there's anything else you'd like to see, if I move too fast or too slow, so you can give me some feedback. I'd love to hear from all of you. Thank you so much for joining us. Did anybody have any questions? I know Dave, okay. I'm just typing in if anybody has any questions. If you'd like to ask questions separately and go through something later, again, at 401-808-9301, and you can call me with questions or about more programs. Thank you, everybody.